Good evening, everyone. This is Meldita and I'm back here at my YouTube channel, MELDITA'S Info Corner. This is my Facebook, johnregacho@yahoo.ca. Okay, yesterday, I spoke about the first example of ventricular tachycardia with pulse. There's a heart rate of 187 beats per minute, but there's blood pressure. Okay, and we deal with this VTACH, the first example with antiarrhythmic medication. So this time, we will be talking about the second example of ventricular tachycardia with pulse. Okay, so here we go. We have here a 78-year-old male driven by the wife to emerge with complaints of chest pain radiating to the left arm, dizziness, and short of breath. There is a history of symptomatic bradycardia, and a permanent pacemaker was inserted, but somehow the ejection fraction, deteriorated. So they upgraded this pacemaker to CRT device for secondary prevention. Because if your EF is low, the patient is susceptible for ventricular tachycardia. So they did this upgrade. Other history, hypertension and dyslipidemia. So the ER nurse checked the patient's vital signs and found out that the heart rate is 150 beats per minute, okay? But there's blood pressure. So the heart rate is regular, but it's fast. And 12-lead ECG was done. There's also blood works done. So the 12-lead ECG done showed here wide complex tachycardia, okay? And the patient is conscious, and there's pulse. So we're gonna find out, are we dealing with VTACH with pulse or SVT with bundle branch block? So let's find out. So let's take a look or review again the VTACH criteria. VTACH criteria says that it should be wide complex tachycardia with 3 or more consecutive PVCs. Well, in this case, we have all throughout wide complex tachycardia. Is there a pulse or not? Yes, we do have a pulse. The patient is conscious and talking. Okay. The QRSs of our VTACH should be more than 0.012. Well, the QRS of this 12-lead ECG is 0.17 to 0.18 second. The rate of VTACH should be at least 110 to 250 beats per minute. Well, we have a heart rate of 150 beats per minute. Is it sustained or non-sustained? Well, this wide complex tachycardia is sustained because it exceeded 30 seconds. Is it polymorphic or monomorphic? Well, it is monomorphic because all the morphology of the QRSs are the same. Is it symptomatic or not? Well, that's the reason why the patient came to emerge, because of the symptoms. Okay, do we see fusion beat? There's none. Do we see capture beat? There's none. Do we have AV dissociation? Yes, I see something. I saw tiny P waves and they are not related to the QRSs. Okay, do we have concordance? Yes, we do have concordance. In analyzing VTACH, you have to check leads V1 to V6. You don't have to check the lymph leads for VTACH analysis. VTACH analysis, you check the chest leads or the precordial leads from V1 to V6. In this case, we have here all negative deflection, all pointing downward. So negative deflection. And my verdict for this rhythm is we have a VTACH with pulse. So, while waiting for the blood work results, the doctor ordered amiodarone bolus, and that was given to be followed by infusion. This medication is ordered. Okay, then the potassium came back. It was low, so we have to give potassium supplement, and the magnesium is slightly low, so we also gave magnesium supplement. 2 hours and a half, the ECG converted. So this is the ECG of the patient. So if you look at it, lead 2, you have here an inherent QRS. We got V-pace, 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 inherent QRS, V-pace, and we have here a fusion beat. That is 2 stimuli stimulating or depolarizing the ventricle, and B-pace, an inherent beat, and B-pace. Sometimes you see 2 spikes, sometimes you don't. It depends. Okay, because CRTD, we are biventricularly pacing the patient, which is a cardiac resynchronization therapy, which is an anti-failure regimen. Okay, looking at these inherent QRSs in here, I suspect the patient might have here a left anterior fascicular block, which you see that on lead 1 and 3. Lead 1, we might have a Q, and lead 3, we have an S. So there is a possible left anterior fascicular block, which is also an incomplete left bundle branch block. Okay. So by history, the patient has CRTD. Before, the patient has a pacemaker. Okay. And then that pacemaker has been upgraded to CRTD. Okay. So there are two pacemaker for the CRTD. And the next video will be about these devices, I should say, with their corresponding strip. Okay. So this second VTACH with pulse, as I said, this is tolerated. The patient has a blood pressure. And we deal with this wide complex tachycardia with antiarrhythmic drug, which is class 3 amiodarone. And we just corrected the depleted lights. And the patient converted back. So what is the plan of our doctor? So the doctor dealing with this problem is an electrophysiologist, and he's going to interrogate the device. Okay? Thank you. And the next video will be about these devices. Okay. Thank you.